Yeah, I think the most important. Can I get the slides fixed? The most important thing for this is I don't think it's a debate in the sense that there's one superior implant versus the other. I think the debate should be how do you refine your indications for one versus the other. One implant is clearly superior for certain patients, and one implant has certainly a role in other patients, and that's really my goal here. But as my father would always tell me, that usually people with a little more gray hair and a little bit more experience make the right decisions. So I'm hedging myself with this debate from the get-go, although I am losing my hair. So what do? You have medial compartment arthritis. You have a very good patellofemoral joint. Your ACL and PCL are completely normal. He's 50 years old. Do you do an osteotomy on grade 4 disease? Probably a little too much. Do you do a uni? Well, maybe, but sometimes a uni can take more bone than a total knee. That's something I want to stress to the audience, is that a mobile-bearing uni certainly takes more bone than a primary total knee on the medial side. Most residents and fellows don't appreciate that concept, where a total knee you're taking 2 millimeters of bone. Some fixed-bearing and mobile-bearing unis take up to 4 or 5 millimeters of bone. Or do you do a total knee on this patient? I don't know. There's a lot of controversy. As I said, let's focus on the proper indications. For me, an osteotomy means that you still have a preserved joint space. You can't be completely bone on bone, and you really want that active patient. A uni, I really want to have an intact ACL, but for that older patient, that 75-year-old, 80-year-old patient, you don't. Even Dick Scott will say you don't necessarily need to have an intact ACL, and that's a debatable topic. But clearly, you want somebody who's less active and lower body weight. Total knee, the ideal total knee patient, as we talked about before many times, is tri-compartmental extensive arthritis. Dr. McDonald was talking about that, and you really want to focus on people with extensive disease. If you have people with moderate disease, those people usually aren't very happy with a total knee replacement. So high tibial osteotomy, we talked about this morning. It's great, right? Well, no, it's not always great. You got to be very clear to your patients how much time they're going to take off. If you have a non-union of these, it can be a big problem. You can create patella baja, you can have hardware breaking, you can accidentally manipulate the slope, not on purpose, but accidentally. You can overload the lateral side, and then these conversions sometimes can be easy, sometimes they cannot be easy. And I talked about this before. I will tell you, a 50-year-old total knee with moderate arthritis are not happy patients. 20% still complain of anterior knee pain or other complaints. The thing that we know, a total hip replacement, they will all say it feels physiological, it feels like my hip. When Dr. Dorr is here many times, my father did his total hip replacement, he always forgets which side was his hip done. A total knee patient usually doesn't forget which side their total knee was done. They don't, they feel so much better, they have so much more function, but since you sacrifice those cruciate ligaments, it does not feel like a normal joint. So, is uni compartment the best for this 50-year-old moderate weight arthritic knee? Well, you have improved kinematics because you have the cruciates. You have improved kinematics because you have the lateral side. It's relatively durable if we give data on mobile-bearing knees. There's quicker recovery. Nobody would debate about that. You can do it with a pretty minimally invasive non-large arthrotomy approach, and you can use robotics or navigation to really make it more reproducible. It's one of my dad's fundamental points that he's not going to ever say that a total knee will give you normal kinematic function. And Dr. Kamasak has shown this numerous times. As soon as you take the ACL and PCL, this will not have normal kinematics. And you can argument CR or PS, regardless, both of them are not normal kinematically functioning knees. And unless you go back in time or go forward in time and try to produce a total knee with an ACL, PCL preserving cruciate axis or a 4-bar linkage, you're not going to get normal kinematics like you will with the uni. And not just the normal kinematics give you a normal proprioceptive gait, and that's really what patients love about a uni-compartment arthroplasty. The second thing they love about it is their function. In terms of going back to sports, when you compare a uni and a total knee, a uni can do more functional sports activities. This has been shown in multiple papers. In terms of actually the level of activity, a uni is superior to a total knee. It's still not as superior as an osteotomy, but they can almost, not completely, but almost maintain their sporting activities after a uni compartment. Now let's talk durability. This is Oxford data, so you always got to check it twice and make sure who's publishing it. But they're giving you very impressive numbers, 97% at 10 years. And this is shown in numerous papers. But there's also data from the Chicago group that shows about 94 or 5% at 10 years. So it's certainly a durable construct. Quick recovery. That's what you love about a uni. These people at post-op day 7, they got great range of motion. They have very little swelling. It's a more minimally invasive operation, and they have quicker return to function in terms of time off. So you can use a lot of fancy toys to maximize where unis have always failed, and we talked about this numerous times in terms of accuracy, using the robot, using custom jigs, which we'll talk about later today, and as well as just plain old navigation. But uni has problems. We've talked about this extensively. The steep learning curve, problems with edge loading, multiple things. The Swedish registry, if anything, just reiterates that. The goal to me is to maximize the positive features of a uni and minimize the negative features. So first, you really want to hone in on your indications. These are the classic Dick Scott indications, which is 6% of all total knees. Of all degenerative knees. You want to be very careful about the Oxford indications, which I think are a little bit too liberal. You want to really maintain your volume. You want to do high volume uni compartment because that really does predict outcome, and the Oxford people would reiterate that. And lastly, you want to refine your surgical technique. You want to take appropriate courses, get appropriate exposure, really hone in on the technique you're going to use any supplemental navigation, jigs, or computer to refine your accuracy. When unis work, they're fantastic. When they don't work, they're definitely the tool of the devil. But this is why you want to do unis. When patients, I think unis are some of the happiest patients in the world once they have a good functioning uni. The problem with unis is that they're growing tremendously in the US. And I'll leave you with this. This is a quote from Dick Scott, and he said, "Evolving from a voice in the wilderness as an advocate of uni to the voice of reason in trying to modulate this craze." So really, it's not total knee versus uni, but it's refining the right indications for uni. Thank you very much.